I'm Charles Bankhead of MedPage Today. I'm at the American Heart Association meeting in New Orleans, where findings were reported from a potential practice-changing clinical trial of early versus delayed invasive treatment of patients with non-ST segment elevation acute coronary syndromes. Dr. Shamir Maida of McMaster University in Hamilton, Ontario, summarized the findings of the study during an AHA press briefing.
We have very good data in patients with a full-blown heart attack that timely percutaneous coronary intervention or thrombolytic therapy is of the utmost importance. The earlier these interventions can be administered, the better the outcomes, including mortality. We have less information on the importance of timing in patients with unstable angina or a threatened heart attack or non-ST elevation MI, which is a small heart attack. Accordingly, we designed a study called TIMAX, which is an international study that aimed to address this question. So we recruited patients with unstable angina or non-ST segment elevation MI. They had to have 2 of 3 criteria: age greater than 60, ischemic ECG changes, or positive cardiac biomarker, and they also had to be a suitable candidate for revascularization procedure. Background therapies included aspirin, clopidogrel, and 2B3 antagonists as per routine practice, and then they were randomized to receive an early invasive strategy, which included coronary angiography as soon as possible and no later than 24 hours, followed by PCI or CABG surgery if the anatomy was suitable. Or they received a delayed invasive strategy, and this was coronary angiography anytime after 36 hours, and this was followed by PCI or CABG surgery. The primary outcome included hard outcomes, death, new myocardial infarction or stroke, and 6-month follow-up. And the secondary outcomes included composites, which included refractory ischemia, which was defined rigorously as recurrent chest pain lasting at least 5 minutes, with new ST segment changes and leading to an intervention within 48 hours or leading to an earlier intervention than one that had been otherwise planned. Not all patients with acute coronary syndrome are equal. Our guidelines strongly recommend that we risk stratify patients into patients who are at lower risk, intermediate risk, and high risk. In this trial, when we stratified patients according to whether they were low or intermediate risk using a score called the GRACE risk score, the 2 strategies were identical to each other. However, in those higher risk patients, which in this trial accounted for approximately 1/3 of the patient population, there was a significant benefit of an early invasive strategy. In this group, a 35% highly significant relative risk reduction in the primary composite outcome. So the implications of these results are that most patients with acute coronary syndrome can be managed safely with either an early or a delayed invasive strategy. However, based on these results, we strongly recommend and we want to reinforce the guideline recommendations for risk stratification, because in the subset of patients at highest risk, early intervention does appear to be superior to delayed intervention, and in these patients they should be taken to the cath lab as early as possible. In all other patients, however, the decision regarding timing of intervention can depend on other factors such as cath lab availability and other economic considerations.
The lack of difference in adverse events between the early and delayed invasive strategies led investigators in the trial to conclude that an early invasive strategy is a reasonable option for the management of all patients with acute coronary syndromes. In discussing and commenting on the findings, Dr. Deepak Bhatt of Harvard characterized TIMAX as the most important study presented at an AHA forum on late-breaking clinical trials.
Let me just put this trial into context. This is the major interventional cardiology trial being presented at this AHA. It's the largest trial on this topic, and it's the largest trial that there will ever be on this topic. Even in the lower risk patients enrolled in this trial, that is patients again coming in with various forms of chest pain and various degrees of heart attack, there was no harm and a potential benefit, presumably a lower cost and definitely a shorter length of stay in the hospital. So from a patient perspective, if it were me, I'd say, take me to the catheterization lab early.
The study's biggest impact may pertain to the nation's hospitals. Centers that have catheterization laboratories will have to balance the potential added cost of keeping a lab open on weekends when they are typically closed versus the possibility of extending the benefits of an early invasive strategy to more patients, including shorter hospital stays. Members of the joint AHA American College of Cardiology Committee on Guidelines for Percutaneous Coronary Intervention held an impromptu meeting immediately after Dr. Mehta's presentation to discuss how the findings might affect recommendations for invasive treatment of acute coronary syndromes. For MedPage Today, I'm Charles Bankhead.